Hello, good evening, everybody. I'm Dr. Binayak Dev, and we are going to start our session of ODISHA Live, conquering complex coronaries. And this is the day one. We'll first have live transmission, and then we'll have case-based learning on complex coronary interventions, imaging, and physiology. The first live case is from Apollo Bhubaneswar, and we'll have amongst us very senior and eminent cardiologists who will be the expert panelist, and myself and Dr. Bikash Majumdar will be moderating the show. So to introduce Dr. Bikash Majumdar, Senior Consultant Interventional Cardiologist at Apollo Multi-Speciality Hospital, Kolkata, and he's done his MRCP from London, and he's also a life member of CSI Royal College of Physicians and British Cardiovascular Society. So welcome to the show, Dr. Bikash Majumdar. You'll be my co-moderator. Let me introduce the expert panels. We have amongst us a very well-known and eminent cardiologist nationally, Dr. Dhiman Kahali. He is very well-known to us. He's the Director of Interventional Cardiology at PM Birla Heart Research Center, Kolkata, and ex-convener of STEMI Council, CSI, Vice President, and Mother Teresa Award winner 2022, National Scholar and National Science Talent Search Scholar, Gandhi Centenary Award winner. Welcome, Dhimanda, to our show. We also have Dr. P.C. Rath, Pratap Chandra Rath. He's the head of the department, Director of Cardiology at Apollo Hospitals, Hyderabad. And Bhubaneswar is Senior Interventional Cardiologist, visiting faculty, University of Rouen, France. And he's expert in intervention, intercardiac interventions and structural heart devices. And he's a very well-known figure in the national faculty in India. We have with us Dr. Rudananda Misra. He is ex-professor and head of the Department of Cardiology, SCB Medical College, Cuttack. Senior consultant interventional cardiologist at Apollo Hospital, Bhubaneswar. He's a teacher and author. Welcome, Dr. Misra. We have Dr. Joy Sannal with us. He is MD, TM Cardiology, and he is FESC with more than 15 years of experience in interventional cardiology. He is currently associated as head of department and senior consultant interventional cardiologist at Nivedita Hospital, Shiliguri. Welcome, Dr. Joy Sannal. We have Dr. Mahesh Prasad Agarwala. He is currently associated with AMRI Hospital, Bhubaneswar, senior consultant interventional cardiologist, and having an experience more than 17 years and a very experienced, renowned cardiologist at ODISHA. We have Dr. Sunil Dwivedi. He is cardiologist from All India Institutes of Medical Sciences, New Delhi, currently associated as consultant cardiologist at Bikram Hospital, Bangalore, and Specialist Hospital, Bangalore, the finest operator and a teacher. Welcome, Dr. Dwivedi. We have Dr. Anupam Jena, consultant interventional cardiologist and EP, Kalinga Institute of Medical Sciences, Bhubaneswar. He's done fellowship in cardiac electrophysiology and catheter ablation from Korea University Medical Center, Annam Hospital, Seoul, South Korea. Welcome, Dr. Jena, to our show. And our live case operator is going to be Dr. Prajoraj Das, Senior Consultant Interventional Cardiologist at Apollo Hospital, Bhubaneswar, for the last 12 years, with more than 15 years of experience in the field of interventional cardiology. Dr. Das did his DM Cardiology from SCB Medical College, is ex-faculty of Nizam Institute of Medical Sciences, and one of the few doctors having triple FRCS, expertise in all complex BTCA and with image-guided cases and devices. So I hand over the session to Dr. Bikash Majumdar, who will be my co-moderator, and then we will hand it over to our live operator. Over to you, Dr. Majumdar, for your introductory words.
Yeah, thank you very much, Dr. Dev. And I hope we'll have interesting case today. And thank you all the panelists. And I would like to go straight to the Apollo Hospital, Bhubaneswar. And you must be ready with your case. And if you are, please do start and explain what the case you are doing today.
Thank you and welcome everyone. Let me introduce my colleague, Dr. Govind. He is a cardiologist, consultant cardiologist. He's with me. Dr. Rebecca, she is our cardiac anesthetist. Here, Munir, AVP, Satya, and other technicians are there. They are our supportive staffs. I'll ask Dr. Govind to present the brief history of this case as well as the angiographic different investigation findings, our imaging findings as well as the plan. Then I'll go up to what stage we have come in intervention in this case. Thank you very much.
Thank you, Das sir. So I am giving brief history of this patient. This patient is a 68-year-old male. He is non-diabetic, non-hypertensive, and non-smoker. Admitted day before yesterday with chest pain radiating to left arm and shoulder, associated with sweating and class 2 breathlessness for last 7 days. And in last 7 days, he is going here and there, having rest angina. And after admission, he is also having recurrent angina in spite of optimal medical treatment. And his ECG showed sinus rhythm with evidence of acute extensive anterior ST elevated myocardial infarction beyond window period. Echocardiography shows RWM in LAD territory. There is mild LV dysfunction and trace MR. Next slide, please. So we have done coronary angiogram, which showed distal left main having 40 to 50% lesion, and LAD is type 3. Lesion starts from the ostium up to the mid LAD. Maximum the percentage of lesion is in the proximal to mid LAD is of thrombus containing lesion. Then diagonal one having osteoproximal 90% lesion, which is a small vessel. Vessel diameter is around 2 millimeter. Then LCX is having osteoproximal 80% lesion, RCA dominant, and distal RCA is 60%. So with this background of history and coronary angiogram, next slide, please. So we are going through a case having double bifurcation stenting, that is left main to LAD and LCX. Again, there is a bifurcation lesion in LAD and diagonal. But because the diagonal vessel is very small and we are not going to stent the diagonal, so our plan of management is elective left main bifurcation stenting with T-stent technique. And as we have seen in the coronary angiogram, the left main to LCX angle is around 90% and LCX vessel is more than 2.5%. So we are going to we are planning to do elective LMCA bifurcation stenting with 2 stent and T-stent technique. Next, I am presenting to Dr. B.R. Das. He will.
Yes. In the meantime, I'll ask my technician. He will show you the running angiogram pictures. No, before the procedure, just angiographic picture, please. This is the right coronary artery. There is a distal lesion.
Can we have the full screen, please? We can't see the full screen.
Sorry?
We can't see the full screen. Can we have the full screen, please?
Full screen. Yes. So the full screen. Are you able to see the full screen now?
Not really. It's just like a small box. It's coming like a small box. Is there any technical team?
Okay, okay. Just 1 minute.
So, sir, you can see in speaker view, sir, mode, not in gallery view. Speaker view mode.
So do we have to do anything from our end or?
Yes, sir. Yes. Go to the right hand.
Yeah, now we're able to see.
Now it's better. Yeah.
Yeah, now it's better.
Go to the left system.
Can I ask Dr. Kahali and Dr. Pisira to give their opening remarks, please, regarding the case?
First of all, it's a complex lesion, cheap lesion, and there is 2 bifurcation as he has told. So let us see how they proceed. I totally agree that LAD diagonal single stent and LAD circumflex, the distal left main bifurcation, I think 2 stents will be required, but we have to keep the procedure very simple. Because what is the procedure you're going to follow? Can you have any plan?
Yes, now my plan is to put, already I have put the stent from left main to LED. Before that, I have done the OCT. In fact, I have assessed the lesion extension up to the mid LM. And the basal diameter is around 3.7 millimeter in the left main. And I'll show you the OCT. Now the plan is to put one stent from left main to LED and then recrossing a wire through the stent to the left circumflex and T stenting, then final casing.
Are you planning just to do a T, or you want to do T and protrusion like TAP?
No, only T.
Only T, okay.
Next.
Is the OCT.
Yes, this is the OCT run in the LED to LM. The thrombus containing plaque in the mid LED.
Professor Rudananda Misra, do you want to make any comments right now?
No, I fully agree with what Dr. Das has planned. In fact, I saw this case and I was there and yesterday and I discussed the case with them. And then I had the same opinion that you should do a imaging and then decide about the strategy. Then we planned that it should be left main to LED, and again you have to two stent strategy to start with. So the point is whether you would like to do a T or a Coulée or a mini cross or a whatever is the operator is comfortable. See. So if the operator is comfortable with whatever technique, I think he should do that.
Dr. Das, if you could explain the OCT which you are showing now.
Yes, yes. You can see, Satya, from the beginning, you just run it. Yeah. This is the mid part. Yes. This is the healthy part. Now the lesion starts there. Yes. Yeah. In the mid part, you go forward. In the mid. Yes. There is thrombus. There is thrombus here, red thrombus, in fact. And this thrombus again. Yes, this is this circumflex ostium. Then it is the left main now. Yes, the left main. We have calculated, estimated the lesion in the left main up to the mid segment, mid part of the left main. That is about how much, Satya? 50%. Sorry, it is 50%. That is why my plan is to put one stent from the left main to the mid part of the, sorry, across the mid LED, and we have calculated the total length. It is coming around 36. In the meantime, I have already, because the patient had anginal pain, I have stented from the mid LM to LED. That I'll show you. Go to the next angiographic view. Next. Next. Next one. Okay, this is the OCT one. You go to the angiographic view. I'll show you. There is some technical problem in the remote. I'll show you.
Did you have any stenosis at the diagonal ostium?
Yes, yes. The diagonal ostium is not visible at all. Okay. Maybe there is complete occlusion in the diagonal ostium.
Dr. Agarwala, do you have any comments to make?
In fact, we pre-dilated both LAD and left circumflex with a 2.5 15 millimeter balloon. And we did a post-dilatation OCT of the left circumflex to measure to know the extent of the lesion to take a appropriate size of the stent. And this is after dilatation. Go to the OCT run of the left circumflex. Yes, this is the healthy segment. From that part onwards, the lesion starts. Some calcification is there. Now into the left main. So the proximal vessel diameter is around 3 millimeter, and the distal part is around 2.75 millimeter. So you go to the LED stenting.
Joy Shanal, would you have any comments to make?
Yeah, good evening.
Good evening.
Very nice case is being shown. I think to a certain extent, Dr. Das is right in choosing this approach. My regards to our professor Hudand sir. He's my teacher. Sir, good evening. And yeah, because we all know in traditional this thing, left main circ LED DK crush or some crush is always better. But since this is an acute MI case and with LV dysfunction, anterior MI, I think basically even if it is a planned strategy, but still then I think it's basically a bailout type of a situation where you're trying to do a T and T tap. But I think it is better that it is maybe a protrusion is done so that good coverage of the circ ostium is done, because the ostium looks diseased on OCT.
Yeah, I take Joy's point actually, because that is the advantage of doing a tap where you are actually making sure that the circ ostium is nicely covered. Yeah.
Yes.
Dr. Sunil
So now-
Dwivedi, your comments, please.
Yeah, no, I agree with the strategy right now. Let's see how it goes. But one thing is that those who are beginners who are seeing that, I think in LAD there was one plaque rupture view was also there. Very good. So people who are using it initially should be watching for that. So the culprit lesion and multivessel they can identify. That's the only point I want to make. Yeah. So it was seen just before or after the thrombus. Strategy-wise, I fully agree with that.
Dr. Brajara Jidas, please carry on.
Yeah. So now my plan is to put a stent. I have already dilated the left circumflex ostium with a 2.5 millimeter balloon. Now I am taking the left circumflex stent. I have taken a 328 millimeter stent.
3.5 or 38. 3.5, 38.
What was the diameter of the circ ostium on OCT?
3 millimeter. Distal part is 2.75.
Okay.
Just wanted to ask, have you done a pot with what balloon in here for in the left?
I'll be doing just because he is having off and on angina. I want to first establish the flow.
Okay.
Can you go for a stent view?
This is 8
Stent
French.
not-
Your guider is 8 French or 7 French.
Another
Dr. Anupam Jena, do you want to make any comments right now?
Stent protocol is there? Okay, just plain scene. Eh? That's fine. Now, one more injection. Yes. I didn't. This is you come to the PA cardiology. I think it is okay. Go to the LA caudal again.
Caudal is better actually.
Go ahead.
Okay.
Deflate. PA caudal, come to the PA caudal. Give a balloon for post dilatation in the left circumflex. Give me
3. नहीं 4 नहीं 3 L6 पे दिया गया.
left circumflex. What is the size?
312.
Dr. Kahali, I would like to ask you a question. When you are measuring the lumen, what kind of imaging techniques would you prefer in this particular acute MI?
I think IVAS will be better in visualizing the left main, but OCT can also be used nowadays, no problem. And as we were talking about the port, I was seeing the proximal end of the left main to the LED stent. I think there is sufficient space for port. And the angiographic picture looks to be very nice, and the OCT picture too. But we would like to have an OCT picture now.
Yeah.
Kissing and everything goes on, but I think angiographically it looks to be good, and I think there is adequate space for port as well. And regarding the type of bifurcation stenting, one of my friend was talking about decay crush. I think it's the right decision not to go for decay crush, because we have to discuss about all the methods. So I think because of 2 reasons. Number one, decay crush has 11 steps, and in a thrombotic lesion, this one, acute MI situation or subacute in both the arteries, too much ballooning is not good. So it's a better method, tap what he's doing. And sorry, I lost the link also in between for a little while, but I was continually observing the procedure. So I think I must congratulate them. They're doing it perfectly well. And the angle is also near 90 degrees. So decay crush, I think this is the case for tap, because the angulation near 90, I should tell, not exactly 90. So
Yeah.
this is, I think, better technique tap. And the amount of ballooning is also less in this one and less cumbersome in this situation. And just I would love to, ask him, the operator, that whether he has gone some viability test and what was the length of the stent inside the left vein, because these are important points for the.
I think the left man, we have kept more than 8 millimeter.
More than 8, okay.
Yeah.
Because we are a little concerned about the length of the stent inside the. 6 millimeter is also sometimes okay, but it's always better to put it a longer one, and if possible what do you think, Vikas?
I took the bigger size stent than estimated. Yeah.
So Dr. Kahali, he actually did a T stenting, not that classical tap. In the
no, but it is little protruding. If you
Oh.
see, the circumflex stent is little protruding in the.
So when we do the classical tap, we actually keep a balloon on the main vessel while we take a little.
Yeah, you see, a portion of the balloon is inside the left main. Amount of balloon is inside the left main. So he has about a millimeter or so in the left main, and I would designate it as a because you can see it.
Just to make sure.
Yeah. So whatever you tell tap or T technique, but it was inside the left main. So I should tell it about a millimeter inside the left main. So I think it was a tap anyhow, but whatever it is, but I think tap is little better than, because everywhere it is accepted, the tap is little better than the T technique. But I think technique wise, it's perfect because, in this situation, going for decay crush, is extremely cumbersome and the flow would have been disturbed. But I was watching that all through the procedure, the operator was fine to keep the flow okay in both the arteries, and the pressure and other things was also all right. So it was a perfect stenting and I must congratulate him. But
Thank
this
you very much.
To keep an eye that if possible, we should from the ostium, if possible, or from the near ostium, so that, and we should also ensure before the procedure that how much length should be in the left main, so that in the rack, that size balloon is available. Because it needs to be done pot with some 4.5 balloon. And
I am also planning that.
Yeah. So I think you have Dr. Dash,
Dr. Sunil Dwivedi, what is your opinion about keeping the stent in the middle of the left main? I mean, there are some people who talk about covering the entire left main because we can have some plaques in the left main which can cause problems.
Yeah, no, it depends upon one length of the left main as well as the disease in the left main. I think both should be taken into account. As we discussed, minimum 8 millimeters the balloon length for pot. And if the left main is long and relatively free of plaque, then you need not cover till the ostium. But if it's a short or in a normal length, there's no harm in covering up to the ostium. That's what we follow. Nothing more.
Yeah. So it's not a long one, Dr. Dwivedi.
4.58
the left main.
Another thing is he did an OCT here, didn't he? So he showed that there is not much disease in the proximal part of the left main, and that's why probably he has decided to keep the stent in the middle of the left main.
Correct.
Dr. Das, can you please explain what are you doing now?
No, the left LED wire come out. I'm just wearing that.
Okay.
Now I'll go for the post dilatation of the left main part of the LED stent, and then I'll go for a OCT run.
Is there any plan to tackle that diagonal or just leave it?
No, I am not planning to go for any diagonal.
Yeah, it's an acute case and acute MI, so.
How much? Okay.
This is a 4.5 balloon you're
Yeah.
using.
4.5 balloon up to 12
8 millimeter.
injection. I think they were sitting now.
OCT.
We're fortunate here we don't have much calcium in any of the.
No, the calcium is very less, except in the left
That's a
circumflex.
good thing actually. Yeah. Dr. Joyce Arnold, any comments?
The nature of the case, I think he has done exceptionally well on the patient having on-table angina. It would be interesting to see the post-stent OCT findings. Since he has post-dilated the stent nicely, so let's see how is the apposition and is there any thrombus or plaque prolapse or anything like that.
Yeah, just pull it.
No. Air.
Dr. Kahali, in
Where is
case
there?
which if you don't have imaging
No.
which is readily available, how do you size the artery when you are dealing with acute MI cases?
See, it's by eye impression, and the majority of the cases in our country, we do without imaging. Even in Europe, I was talking with many of the legions, and all of them are of the opinion that they also do 85% to 90% of the patient. Even Frenek is the president of the Bifurcation Society, EBC. He also tells that more than 15% imaging. But of course, in some of the US centers, they go for 90 to 100%. Like Ramesh, where he works, he tells that all my colleagues do 100 out of 100 imaging. So the situation differs across the Atlantic also. And I think in average, except for US, average 15 to 20% of the patients or the operators go for imaging. In some centers in Europe also, they go for more of imaging, say 50, 60%. And it's not mandatory that left main. Okay, it's better if you can go for imaging, but it's not that you can't go without it. We have patients who have been doing very well for the last 10, 12 years with left main stenting, and there is no problem at all. And subsequently, we have seen the patient, we have done the angiography, they have been doing quite well. So it's not mandatory, I think, but okay, if the lesion is calcified, if the lesions are very critical, it's a bifurcation stenting, then of course we have to think of stenting. I mean imaging. Yeah.
Can you explain, Dr. Das, what you're doing now, the OCT imaging?
We have just finished that OCT run.
Processing now.
Yeah. The LED and left main. The processing is going on. I'll show you the pictures.
Yeah, it's nice.
Both apposition and stent expansion is increased.
I think the apposition of the stent is very nice.
Looks very nice actually. Yeah. Very nice.
Yeah, apposition is good. Yeah.
Expansion is also good. Yes, the left circumflex stent is just at the ostium. There is no.
You really got the ostium absolutely correct there.
Yes.
It's very nice.
Just protruding.
Just protruding, yeah.
Very nicely done.
I saw that though there is not much of the protrusion, but there is little protrusion of the stent. I think it's very well done. The ostium of the circumflex, which is the Achilles heel in distal left main stenting, I think is very well done. We must congratulate Dr. Dash.
Thank you, sir. Thank you so
Very
much.
good
Professor
result. The
Mishra,
position is very good.
can
The
I ask
sizing
you,
is very good. Flow is very good. Everything is good.
Professor Mishra, what kind of views do you take angiographically while actually doing the LCX ostium?
See, all proximal lesions you have to take based of the ostium. You have to take if it's a proximal lesion, you have to take the caudal views because that opens up the ostium very well. But when you do a bifurcation, you cannot rely on a single view. You have to take multiple views because that gives a clear impression. If you are not imaging and you are doing without imaging a left main or a bifurcation stenting, a single view we cannot just depend upon. You have to take multiple views and then you decide about the stenting and the strategy. As Dr. Kahli has rightly told, we have done cases when there was no imaging. And for several years in this country also. Now that imaging is available, it has made the life of interventional cardiologists a little easier. But we have been, all senior cardiologists have done it without imaging.
Absolutely, absolutely. Even now, Dr. Mishra, even in Europe also, majority of left main stenting are done without imaging. Though it should be done if it is available, if it's actually not a problem. But in our country, finance is a big problem. They don't have the money to put a stent. And so we can't think of always going for imaging. It is better, of course, if we can go for it. Don't doubt that the position can be seen, whether there is, under expansion of the stents, how is the fracture of the calcium, all are better visible, no doubt.
Right,
but
right.
The money is not there from we are going to do, and we have to depend on the experience.
Dr. Kahali, I think there are a couple of things here about imaging. I think one is the financial issue, and other is actually the believers and the non-believers of the imaging. Particularly France.
There is no question of non-believers. Imaging is
the French people. They are. I think talking to them, they feel that the experience they gather from interventional cardiology they can do without imaging. Particularly the French.
No, what do you tell? I can't understand. I'm
telling the operators in France, mostly they believe that they can get away without imaging. They hardly use any imaging. It is not always about the finance in that particular country.
No, Mark Silvestri and all people in France, they go 15% cases maximum. Even in left main, they go for 15-20%.
Exactly. Yeah.
Personal communication, even Joe Fajade talks about ticagrelor. You tell how many patients actually there are resistance with clopidogrel. I know there are few, well, yes, very few, not few, very few. So that's the thing, because ticagrelor is very costly over there, even prasugrel.
Dr. Das, if you can explain what you're doing now.
I have taken the final injection. I have removed the wire, everything. Satya, can you show both the injections? I have taken 2 caudal view as well as 1 cranial view.
Yeah, I think it's very good apposition. It looks to be nice also. Yeah, take a good picture and show last.
Yeah, last injection I am showing.
Yeah, show us a final picture. And
will you do any OCT of the circumflex stent as well, or even not?
That I can do, but as I saw that circumflex stent is well positioned at the ostium. That is why now I am not intend to do, because the contrast load will be more, and he is already LV is 40% like that.
Okay, that's fine. Thank you. Your LED flow is nice, isn't it? It's
yeah.
A very good result. Actually, final result is very good. We must congratulate us for this excellent
absolutely.
Right.
Very well done. Very well done. Very good result. And in such a scenario, LV dysfunction, LVDP must be also little high and, full of thrombus, but very well done. The pictures are excellent. OCT pictures are very good. And I think an excellent piece of exhibition. Very well done. Dr.
No, that is
Dash.
the
Thank you so much.
apex lesion made simple.
Yeah. And
Okay.
I completely agree because you see the angle, it's more than 90 degrees. So decay crush should not be done in such angulation. That is also important. Secondly, with so much of thrombus containing lesions, decay crush should not be thought of.
So Anupam Jana, do you have any comments, please? Dr. Dwivedi, so I think when you are deciding about bifurcation stenting, it's not always the anatomy, it's also the scenario, case scenario, which also dictates what kind of techniques you're going to use. In this particular case, we had a case with thrombus burden with acute MI. So the scenario changed probably, is it?
Yeah, I fully agree because ultimately we have to give a comprehensive result, not only anatomy.
Yeah, absolutely.
And the one important thing for beginners or who are just in the middle of their learning curve, that one important thing should remember, according to me, is that all of us will be well versed with one or two techniques much better in bifurcation. So in case of emergency, you follow the technique which you are very quickly well versed with that. Sometimes it may not be most appropriate, but it happens. So practice with a strategy also is important, what you have done, which sometimes is important. Some people are very good at culotte, some people are different. Although you need to fit into anatomical case scenario, but to try not to do it, that strategy which you are not done enough or well versed or to do it quickly. This is also important according to operator experience.
In the European scenarios, it's more about culotte, and in the Southeast, it's more about the decay crush. So we Indians, which technique do you think we are comfortable with?
I think a lot of us are now doing most of the techniques. DK crush and tab. A lot of us are doing regularly. Culotte, I'm not sure how many of us are doing. You can tell better, but I've been doing culotte earlier. So what I see is that senior level, most of us are well versed with all these three basic techniques, important techniques, and we can use it accordingly. But those who are beginning to learn, I think they should know DK crush and tap. This is a must. These two things they should know.
Yeah, absolutely. Very vital comments. Yeah. And it's very important that who is proficient in what technique, he should first go for it, if possible, if there is no contraindication. And there is no doubt that decay crush is a very good technique because in Cheng series, the lesions were more lengthy, there were more calcification, more of osteal disease, side branch length of the lesion were more. So there is no doubt that the group of patients in his group were much severe disease than the EBC techniques. And there are non-believers of EBC postulations in EVS also. You have heard from Shamin that he doesn't believe that they tell that the side branch balloon should be 0.25 millimeter more because the opening is oval in nature. Shamim has done some, hemodynamic studies with, very intricate hemodynamics, and he has found that these all are not true. He was commenting in a bifurcation lesion program. So he doesn't also believe in, I personally tell his name because he was very firm in his conviction and that these EBC postulations are always not true. And the EBC group of patients were much easier group of patients.
Okay. Thank you, Dr. Das. It's a nice case. You want to, Dr. Dev, you want to summarize and then final comments?
Yeah, I think in all, we had a wonderful case to begin with. It was a difficult case, but I think as Professor Misra told, it was made easy by the way the operator thought. Because I think in this particular areas, the thinking process is so important before you start doing the case. So I think it was thought very carefully, and it was discussed yesterday also. And then I think the way it was done, it was very, very good, particularly getting the ostium of the circumflex with stent, just maybe one or two struts protruding. That was an amazing, skilled case. The OCT definitely helped in this case. And of course, our experts, Dr. Himan Kahali, Dr. Sunil Dwivedi, Professor Rudananda Misra, Joy Sannal, Dr. Agarwala, I think they contributed a lot in the understanding of the case. So I think in all, we had a good live case. Thank you, Dr.
Thank you very much.
Rajaraj Das and your team. I think a good hand
Yeah, I think.
was
Thank you. Thank you.
well done. Over to you, Bikash.
Yeah, I think this is a nice case, as the importance is first to keep it simple when you are doing with a acute case with thrombus. So the approach was excellent in a way that kept it very simple, had the advantage of having imaging. So you can have, proper sizing of the vessel and proper planning, stent sizes and everything. And then technique wise, T technique is relatively simpler technique compared to the decay crash. And of course, decay crash is not at all feasible in this particular case because of the angle of the bifurcation, and as well as it would have made things much more complicated. So he kept it simple and nicely completed with a very good result in the infarct-related artery with a good flow. And also the circumflex was treated nicely. And with the OCT post-procedure, he demonstrated that the stent apposition was absolutely fine and the circumflex ostium was nicely covered. So nicely done case. And I would say that there's a huge congratulations to the entire team for the planning and the execution, the way they did it.
Thank you again, all of you. Thank you very much.
Dr. Das and your team for the wonderful case. So we come to the end of this live case session, and we'll start our next session at 7 p.m. I would request our panelists also to be present in that session and make this ODISHA Live conference a great success. Thank you, everyone.
Thank you.
Thank you very much.
Right. Archie.
Yes. Thank you.
Hello, Tanu. Hello. Everybody left.
Atanu, do you have our speakers on board?
We'll start in another 4 to 5 minutes, sir, after the countdown. Yeah.
Hello, Dr. Girish. Professor Smith Srivastav. Good evening.
Good evening, Dr. Deb. How are you?
Yeah, I'm good. Nice to see you again.
My pleasure.
Yeah.
You have got a very nice background, sir.
Yeah, this is our Coronary.
Coronary Sun Temple. Yeah.
This is my home state, actually, Dr. Smith.
So I'm around, sir. Whenever you say we'll start, sir.
Sure. Yeah, Dr. Girish is also with us.
Sir.
Good.
Hi, Dr. Girish. How are you?
Very fine. I wish I could put Bangalore High Court or Vidhan Sabha, but I'm sorry.
Dada, अंदर तुम stand जो
Hello, good evening. This is ODISHA Live, conquering the complex coronaries. We have just finished our first session of a live case, which was very well done by Dr. Das's team at Apollo Hospital, Bhubaneswar. Now is our second session, and we'll be having 3 talks. One by Dr. Girish B. Navasundi, second one by Dr. Sarath Kumar Sahu, and third one by Dr. Chandan Saurabh Mahapatra. We have with us eminent cardiologists of the state and outside the state as well. We have Dr. Satyanarayan Rautrai. We have Dr. Girish B. Navasundi, who is also a speaker. We also have Dr. J.K. Pati, Professor Smith Srivastava, Dr. Panchanam Sahu, and Dr. Sarath Kumar Sahu. So, introducing Dr. Satyanarayan Rautrai, he is the head of the Department of Cardiology at SCB Medical College, Cuttack. A very senior cardiologist and teacher and mentor, and a renowned cardiologist of Odisha with many publications in national and international journals and association with national and international body and congresses. We also have with us as a speaker and an expert panelist, Dr. Girish B. Navasundi. He is the chief cardiologist and director of interventional cardiology at Apollo Hospitals, Bangalore. He has 2 decades of experience in various interventional procedures, more than 12,000 angioplasties and hundreds of device implantation. He is also in the forefront in accepting newer technologies and is renowned doctor for OCT guided complex PCIs, rotational atherectomy, and quite a few cardiologists have been trained under him. Dr. Navasundi has also demonstrated his skills and knowledge through multiple live cases and lectures in various national and international forums. He has been felicitated with many national awards for his outstanding contribution towards interventional cardiology. Welcome to the forum, Dr. Navasundi. We also have Dr. J.K. Padi, who is MD from SCB Medical College, Cuttack, and DM Cardiology from CMS Vellore. And also he has trained in complex PCI from Coronary, Italy, and has a wide experience in interventional cardiology. Currently, he is associated as director in departments of cardiology at AMRI Hospital, Bhubaneswar. We also have with us our friend, Professor Smith Srivastava. He is CSI CG Secretary, Associate Professor of Cardiology at Pandit Jawaharlal Nehru Medical College, Raipur. He's an excellent teacher, an excellent operator, and has many publications in national and international journals, scientific associations, and many of the renowned congresses. Welcome, Dr. Srivastava, to this course. And we also have with us Dr. Panchanam Sahu. He's the head of the department and senior interventional cardiologist at KIMS Hospital, Bhubaneswar. He's a very experienced and senior and well-respected cardiologist of Odisha, having many publications and associations in national and international congresses. Welcome to this forum, Dr. Sahu. And we have Dr. Sarath Kumar Sahu. He's completed his MD from MKCG Medical College, Berhampur, and DM Cardiology from SCB Medical College, Cuttack. Currently associated as head of the department of consultant interventional cardiologist at some Ultimate Hospital, Bhubaneswar. He's a proficient operator and had many publications in national and international journals. With these introductions, I'd like to welcome Dr. Girish B. Navasundi for his first topic, which he's going to talk on stent design and polymer science. Over to you, Dr. Girish. I think you are muted, Dr. Girish. Please unmute. Yeah, thank you. Not able to hear you. We also have amongst us Dr. Anupam Jena, consultant interventional cardiologist at PP Kalinga Hospital, Institute of Medical Sciences, Bhubaneswar, and he is trained in catheter ablation in Korea University Medical Center, Amam, Seoul, South Korea. So he will be our expert panelist.
Yeah.
Yeah, we can hear you now.
Can you hear me?
Yes, I can hear you.
And can you see my?
Yeah, we can see your slides as well, but you are muted again. Please unmute yourself.
You know, it's strange. Every time I share my slide, I get.
You're going into the mute mode. Yeah.
Why is that so?
Our support team, DD production, can you help Dr. Girish? Atanu?
Sir, you can share now. Yeah, it's now. Yes, it's now. It is visible.
No,
sir.
but he's muted again. Every time he's sharing it.
Yes, now it is fine. Now it is fine, sir. Yes, sir. Now you are unmuted and we can see your slide as well.
He's muted again. Atanu. Atanu, Dr. Girish is muted.
Why do I get muted?
DD production, can you help them?
Let me share again.
Yeah.
Or can someone else share my slides if I send them across?
Atanu?
Yes. Yes, sir. Yes, yes.
Yeah.
You can
Could you request the next speaker, then by which time they would set it right?
All right. Okay. So we have with us Dr. Sarat Kumar Sahu. Is he around?
Yes.
Atanu?
Yes, sir. Sarosu is available, sir.
Okay, Dr. Sahu, then could you actually present your case, RCS CTO retrograde angioplasty?
Yes.
Yeah.
Am I audible? Am I audible?
Sir. Yes, sir.
You are audible, yes.
Okay, sir. I am sharing my screen. My screen is visible, sir. My screen is visible.
Yes, it is visible.
Okay, sir.
Thank you.
respected chairperson, expert panelists, and my senior colleagues. Good evening, everybody. Today, I'll present one case of retrograde angioplasty, and it is a RCA CTO, and what complication I have faced, I will describe it. My patient is a 65-year male patient. He is a non-diabetic, non-hypertensive. He had chest pain, suggestive of angina 4 days back. ECG showed involved anterior MI. Echo showed RWM in LED with ejection fraction 40 to 45%. His angiogram, I will describe it. This is his angiogram. Left main is normal. Left main is normal. LED, if you see, is very tight block, around 99% stenosis with TIMI1 flow. This is the LED, very tight block with the TIMI1 flow. LCX mid segment is also diseased. It is around 50 to 60% diseased. RCA is filled retrogradely. This is right coronary angiogram. RCA is diseased from proximal part. Proximal part is around 50 to 60% stenosis. From mid segment, it is totally occluded. So with this, we plan for PTCA angioplasty after explaining the merit and demerit of CABG and PTCA. Patient agreed for PTCA because it is acute lesion, and with a TIMI1 flow, we prefer PTCA. We did the first angioplasty of LED because it is tight block. LED was 99% stenosis with TIMI1 flow. As usual, we pre-dilated with a 2 into 10 millimeter balloon. Then we put a stent 3.5 into 19 millimeter and did good post-dilatation with 3.5 and 4 meter balloon. Then this is the result after LED PTCA. We knowingly put a short stent to spare some collaterals, septal collaterals for future in situ angioplasty, RCA CTO. These are two collaterals, septal collaterals. We knowingly preserve it. We did not cover the other 50 to 60% lesion in the mid LED. Then after 5-6 days, we plan for the RCA CTO. This is the dual injection for RCA CTO. We took a 7/8 guiding right Judkins for RCA and a 5/8 diagnostic for LED, and to get dual injection. And we plan to do the CTO after analyzing the angiogram. If we see the RCA, the osteoproximal segment is healthy, it is large size vessel. From proximal segment, it is 60% stenosis, and from mid segment, it is totally occluded. So, and if you analyze, the CTO is filling retrogradely, and the length seems to be more than 20 millimeter, and there is an acute bend more than 45 degree, and this CTO, this proximal cap is tapered, and there is no much calcification or thrombus. So this is a fast attempt. With this, we calculate the JCTO score is around 2, and there is good septal collaterals. So we plan JCTO score is 2, so it is intermediate, means chance of crossing the CTO. So CTO crossing within 30 minutes is around 50% in this case. So if you plan a CTO, we have to take hybrid approach to get dual injection. And if these things are present, like ostial occlusion, poor distal tag rate, significant side branch occlusion, significant side branch in the CTO segment, severe calcification or tortuosity, good septal collaterals, then we can plan for primary retrograde. If these things are not there, we can plan antegrade approach. If the lesion length is less than 20 millimeter, we can do antegrade wire excavation. If lesion length is more than 20 millimeter, we can go for antegrade dissection and re-entry by either control by cross-prosthetic device or wire-based knuckle-wire technique. In a retrograde approach, we can do a retrograde two lumen function or retrograde dissection and re-entry. So with this, because always we should try for antegrade for few minutes, then we plan for retrograde. So as usual, I tried antegrade initially. This is a 86-7F right hook means guiding, and this is for means retrograde injection. So I first tried with a regular wire, means Renat wire, with a guide means 135 centimeter here, and it did not cross. Then I took a XTR, it did not cross. Then I took a Gaia 2, it went to another channel. Then I did a means parallel wire technique with taking another means Gaia 2 wire. So it is again some another place. It is not going through to the distal vessels to remain. Then with this, I tried because a good collateral was there, septal collateral. I planned to try retrogradely. This is the retrograde approach. What I did, we take a 6-8 Judkins guiding. Then this is 150 centimeter course here, microcatheter, and we engage the septal collateral with a regular Renat wire. Then we cross the Renator, we engage the microcatheter. Then we take an injection, septal angiogram, and this septal seems to be connected with the PDA. Then we tried with a cyan blue wire, it did not cross. Then we took a filter XTR. Then it crossed to PLV, a PDA. Then we reached to the CTO segment, distal cap, with this wire, this filter XTR. After that, we put this microcatheter onto distal cap. So there are different options when our wire reaches to the distal cap. We may directly cross to lumen puncture, or we may keep the retrograde wire as a marker and we place antegradely, or we can do reverse cut or cut technique. Reverse cut means we have to put a balloon antegradally and cross the wire retrogradely. Cut means we have to put the balloon retrogradely and cross the wire antegradally. So this is the algorithm. When CTO distal cap is reached by the guide wire, so we have different options like that antegrade crossing, maybe kissing or wire on just marker. We can have a retrograde to lumen puncture that I have described. So after retrograde to lumen puncture, we have different options. We can retrograde balloon retrogradely and followed by antegrade wiring. We can deliver stent retrogradely, or we can do wire externalization, or we have different access technique like antigen microscopy, this technique, or reverse cutting. Then coming to dissection and re-entry, we have cut, reverse cut, knuckle wire, or constant balloon techniques. So here, what we did, I crossed the CTO with this filter XTR and through the true lumen and enter this antegrade guiding. This CTO means XTR enter the antegrade guiding. Then I put this microcatheter into the antegrade guide. After that, I take out this XTR wire and put a RG3 wire and did wire externalization. After wire externalization, then I pre-dilate the CTO segment through this over this retrograde means RG3 wire antegradely, and after that, this is the result. This is opened. Then I wire the CTO again antegradely because the channel was already out. Then after that, I tried to take out the retrograde gadgets. But what happened? I was unable to take out the retrograde wire because it was trapped. Then what I did, I took this antegrade microcatheter over this retrograde wire, this is the posture, and passed up to the LED. Then it was easier for me to take out the retrograde wire. And this is my antegrade microcatheter in this sector. So this means RC to the collaterals. Then I wired through this microcatheter. After that, I put 3 stents from the crux up to the ostium, means 2.75, 3 and 2.75, 2.7 and 3, and did good post dilatation. And this is the final result. So my take-home message is most common failure mode of CT intervention remains the inability to successfully cross the CTO with guide wire. Then retrograde approach through collateral channels is used to cross complex CTO when we have failed antegrade approach ostial occlusion, large side branch at proximal cap, small or poorly visualized distal vessels, long means CTO, long occlusion like more than 20 millimeter. When there is severe toxicity or calcifications, CTO without stomp, older often long duration CTO. When there is difficulty in engaging the antegrade CTO, when there is anomalous origin. And the retrograde tool event puncture, which happens in 30% cases, it is easier to do. And next common method is reverse cut. And with both this technique, in 90% cases, we can cross the CTO retrogradely. So sometimes means complication occurs during retrograde angioplasty. In my case, there is a retrograde RG3 where is an entrap. This occurs in 1.2% of cases. This is because of collateral spasm or rotating the wire more than 180 degrees in one direction, rotating the knuckle wire instead of pushing, kissing the antegrade retrograde microcatheter over the same wire that can cause entrapment. So this can be managed with vasodilators or advancing the microcatheter over the RG3 wire, which is the this guideline. Thank you for patience listening. Thank you all.
Thank you, Dr. Sahu, for your excellent presentation. May I begin? We'll have a short discussion before we proceed to our next speaker. So, Professor Smith Srivastava, do you have any comments to make or any questions? Professor Srivastava?
Yes.
Yeah.
Sir, excellent presentation and probably a very, step by step how a textbook teaching would go. So there are, he has not left anything which is not prescribed in a textbook, and finally outcome is also very good. That is all I can say for Dr. Sahu, and I congratulate him for a very good case.
Thank you, Dr. Smith.
Dr. Girish, your comments, please.
Hi, Dr. Sahu. I'm very proud that it's a wonderful case that it's a good show. Honestly, I think the strategy to quickly move to retrograde was the wisest. What's important in dealing with CTOs is how much time you have for plan A and when do you move to plan B. Because only one strategy may not work, even in the antegrade if you pursue. Second, I think my only concern was two wires went very, very deep. The antegrade wires. Okay. So that is something, we must look at not going beyond 2-3 centimeters from the occluded lesions so that we don't have hematomas or at time perforations. But as I said, a beautiful display of retrograde, and you much simplified it by, exchanging the wire into the, it serves the retrograde direction instead of an injection. But I'm very glad. There's a good case to show.
Thanks, Dr. Girish.
Thank you, Dr. Girish. Dr. J.K. Padhi, your comments, please.
Yes, sir. It is a very nice presentation by Dr. Sahu. It was my concern about that antegrade, the hardware they used, and it goes so deep that I'm very fortunate there is no complications. Otherwise, the retrograde, the way he did it is excellent. I'm happy to see this.
Thank you. Dr. Anupam Jana, your comments?
Excellent case, sir. So, very nice demonstration of the retrograde technique. One of the reasons for wire entrapment is early removal of the retrograde microcatheter. So, we should be careful not to entirely remove the microcatheter before removing the RG3, because RG3 is a 0.008 very slender wire. So, it should always be removed in the support with a microcatheter. Probably I would have kept the retrograde microcatheter near the donor vessel. So that is one of the reasons for wire entrapment.
Thank you, Dr. Jana. May I ask that any of the panelists can take it? What is the role of IVUS imaging while you're doing a CTO, Dr. Girish?
Yeah, I think it has role in two situations. One is when the occlusion, CTO segment is a blunt and a side branch originates at that angle. Then you can take the side facing IVUS and position it in the side branch at the origin and take the wire to puncture the main vessel. Oftentimes it happens that there's a blunt end and a branch comes out and you don't know where to poke. I think that is where a live IVUS guidance greatly helps. It will tell you whether in the true lumen, what is the direction of your movement. Second situation is if you have a end-on IVUS, which is currently not available in India. If you have a CTO, you can use this end-on IVUS, which sends the arrays straight forward and gets you an image. What we currently have is side-on views. So if you have an end-on IVUS, which is available abroad, it helps you to really look at the plaque, the cap thickness, the direction of penetration. So for now, what is available in India, only if there is a side branch, then it will guide you. And once you cross the wire, it's very, very important to know how much you have gone subintimal, what is the length of the traverse of subintimal, and then you have entered the true lumen. And what is the constitution of the plaque? Is it calcific, fibrotic? So that you know what tools to use, cutting balloon, stent it.
Okay, Professor Srivastava, what kind of collaterals would you want septal to be your path for the collaterals, or would you want end-on LED for the path for the collaterals? Which one do you prefer most?
Preferable would be a septal collateral would be a preferred one if it is having a good dia and a more or less straightforward post, because that is what septals offer best. So they have a perpendicular, more or less a straight post throughout, and then they also have a backup security that a rupture may not result in a catastrophe and can be managed. So
yeah, I think Dr. Sahu used a small stent in the LED to make sure that the septals were intact. So that was a very good decision to take. Thank you, Dr. Sahu, for your excellent presentation of this case. We move on to our next presenter, Dr. Girish, for his stent design and polymer science. So he's going to talk on that. Could you share the slides?
Yes, now we have the slide. Dr. Girish had already shared it. Yeah, now it is visible.
Thank you.
Yes, sir. Yeah.
It may sound very boring, but this fundamental understanding of the stent, that is the design, the metal, the polymer, and the drug is very, very crucial, and the balloon and the delivery systems for choosing the right stent in most situations. So I'll be speaking on drug-eluting stent design and polymer impact on long-term clinical outcome. Eventually, we should be driven by not which stent is easy to implant, but which is going to help the patient to have least events in a long run. And if we need to reskill ourselves, we must to use the most evidence-based stents. When you look at a stent of current generation, the stent choice, choose the right one. How do you know there are so many? There's a bare metal stent, the sirolimus eluting, paclitaxel, zotolimus. Then you have, cobalt chromium, everolimus eluting stents. So you need so much confusion. Now let's go to the fundamental basics. A stent component has 4 critical components. That is, one is the drug. The drug coated on the stent provides a local biological effect and inhibits the proliferation of neointimal hyperplasia, we all know. But each drug has slightly different characteristics and benefits. Second, the coating technology, what you call either a polymer or non-polymer based. This coating technology protects the drug and carries the drug and controls its release into the wall. Third, the stent per se, the scaffold. It scaffolds means embraces the vessel and carry the drug and polymer along with it. Last is the design of the stent. The delivery system of the stent. How do you deliver the stent to the patient? Whether it's trackable, whether it's pushable, all that depends on the delivery system too. So there should be a proper balance between all the components of any drug-eluting stents that you have when you look at the stent design. The strut width and strut thickness, both are important. That that helps you to know how much of the vessel will be scaffolded by the metal, how easy to bend, that is track the stent. Then the flex connector design, it will tell you about the flexibility and the material that's formed of, that will speak about its tensile strength, and also the thickness of the struts will be decided on the material characteristics, and also the visibility under fluoroscopy. Then the number of legs and crests, they're very important. They'll tell you how much that stent can be expanded to maximum, and what will be the side access through each of the cell. And then there is cell and link lengths, and then ring face stent pattern. All these needs to be understood. When you look at the material and design, you know, in all these balloon expandable stents, you either have a stainless steel alloy, which is corrosion resistant, biocompatible, and relatively high radio obesity. That's the greatest strength. You have stainless steel 316 or a platinum chromium. Then you have cobalt alloys, such as again, these are biocompatible, very high radial strength, excellent radio obesity, and can be, the strut thickness can be thinner with this cobalt alloy. So you have cobalt chromium and cobalt nickel in this. Next, let's look at the stent design. This will help us to understand the link and the cells. There are, for example, we are showing you 4 stents here, the commonly used: Zymes, Synergy, Orsido, and Onyx. When you look at these Zymes, it's got an excellent radial strength. We all know if it's a left main, that's what you want. Excellent longitudinal strength. Again, if you're doing any osteal lesion, especially in the left main or osteal LAD or a circumflex, where guide may go and bang into that proximal part of the stent, deforming, causing longitudinal deformity, especially when you have a large size NC balloon and you want to pull it back into the guide may get sucked in and hit the stent. You have the greatest protection against longitudinal deformity with Zymes. Then you also have a very low metal to artery ratio, means how much metal is opposing to the wall and rest of it is empty for the endothelium to be in contact with the blood. And also how quickly this metal which is in contact can be endothelialized. All these are important to understand. There's a low metal to artery ratio of just 10.4%. The next stent is the Synergy. Again, the Zymes, you need to remember that it's a 3-link and the connection is between peak to valley. From the peak of one to the valley of the other is the connection. Next comes the Synergy, which are 2 links, 4 links between 2 proximal end of the rings to give you a good longitudinal integrity. So that's what the Synergy came with after the Promus. So when you look at the compromise here, when you look at the slight challenge is the longitudinal strength could be slightly less compared to the Zymes, and good radial strength, high metal to artery ratio. Instead of 10.4 in Zymes, it becomes 14%. So you expect more metal, longer time for endothelialization, and more the metal, you would choose to have less metal. Then there's a warning from FDA on longitudinal stent deformity. We know that. And now with the Synergy, it's slightly better. Going to the Orsido, again, it's a 3-link mid-strut link. So here, the link is between in the mid segment of them. It's got excellent radial strength, excellent longitudinal strength, but there's again slightly higher metal to artery ratio, about 12.3. When you look at the Onyx, it's just a 2-link peak to peak connection. It's got a good radial strength, excellent longitudinal strength, but it's got the highest in terms of metal to artery ratio. There's a lot of metal that comes into contact. When you look at the strength of the metal, the tensile strength of the various alloys, when you look at the L605, which is cobalt chromium, which got the highest tensile strength of about 1000, which is the Zymes platform, and then you have platinum chromium, which is slightly lesser. Steel is the least. And when you look at the Synergy 2, Promus Premier, Promus Element alloy shows significant amounts of longitudinal stent deformity in internal bench testing. We were aware of that. What is most important for an implanter is the marker position on the drug-eluting stent delivery system. what it tries to tell you is every stent you use, you must know when you're positioning at the ostia where the stent starts in reference to the marker on the stent delivery system. Normally, the best one is the Zines, where when you look at the Zines, there is a zero difference between the center of the marker on the balloon and where the stent begins. So blindly, wherever you see the marker, you know that stent begins there. So especially if you're doing an ostial or a bifurcation, it becomes very, very easy for you to position. But when you look at the next best is orsido, it starts from 0.7 millimeter away from the marker on the balloon. So it doesn't start right from the balloon marker. So you may get misled. And the worst is with resolute onyx, which is about 1.2 millimeter from the marker on the balloon system. So be very, very aware. You can use any of the stents, but please be aware that the stent is not going to start from the marker in all of the stents except in Zines. And when you look at the distal stent mid marker in both of them, the distal stent to mid marker is 0 in Zines, and when it comes to onyx, it's 1.2 in the distal stent, and proximal is about 1.1. For synergy, both proximal and distal are 0.9, and orsido 0.7 proximal and distal. So please be aware when you're overlapping or positioning the ostium. Another very important aspect for a cardiologist is how you access the side branch when you're doing across a large branch or you want to do a bifurcation stenting. You always look at the gap, the largest gap that is found between the the stent struts. When you look at the probability, the maximum circular axis diameter, what we call MCAD, when you look at the entire balloon, here if you see, the smallest profile balloon is about 0.021, and the spherical area that can fit inside Zines platform is about 1.07 millimeter. So it's almost 5 times the minimum diameter of the balloon that you can take in. This, the Zines is 1.07, and the maximum with Synergy, which is about 1.09 millimeter. So Zines and Synergy have the best side branch access whenever you consider accessing the side branches. And it's least with orsido, then becomes onyx is the next least, and then the Ultimaster. So when you're looking at side branch access, please prefer one of these two, Zines and Synergy. Look at the probability of maximum circular axis diameter profile device crossing is smaller as only specific locations fit. And Zines 3-link design has one of the highest maximum circular axis diameter. Now, when you look at the polymer, it's a very, very important thing. We know now that drug delivery can happen without polymer or with polymer. So what are the advantages and disadvantages? When you look at the Zines, the polymer is the polymer type is what we call PVD or HFP. It's a fluoro polymer. What is used in Resolute? It is a BioLink. It's an acrylic polymer blend, and in Synergy, it's a biodegradable. In Zines, it's a permanent, but in Synergy, you have a biodegradable polymer. Again, in Ultimaster, you have a biodegradable. Orsido has a biodegradable, as well as Biomatrix and Nabori. Only in Zines, you have a permanent polymer. Coming to the thickness of the polymer, it varies between about 4.8 millimeter up to 16 millimeter. Zines has 7.6, Synergy just 4, Resolute 4.8, but highest with Nabori and Biomatrix. Drugs, we all know Zines and Synergy have the same drug, everolimus. Resolute Onyx has zoltrolimus. Ultimaster and others have sirolimus, and Nabori has Biolimus, and Biometric has Biolimus. Now, When you look at the drug, which is the most important component to prevent the smooth cell proliferation following the injury of stent implantation, the all limers drugs act through the same mechanism. And where do they act? They act as cytostatic agents. They're not cytotoxic like an anti-cancer. The cell remains in a G0 phase and it does not proliferate. The point of no return at which cell commits to completing the cell cycle and it does not go into S phase, G2 phase or M phase. So it is a cytostatic agent. So it does not kill the cells, but it prevents proliferation. And all the drugs that we spoke about are all are limers and all have the same action. So now it comes down to the polymer. Now look at the Zions polymer. That is the fluoropolymer. It stays back on the stent to protect the stent, a phenomenon known as fluoropassivation. Means the job of the polymer is not just to elute drug or protect the drug, but also once the drug is eluted, stay on the stent and help endothelialization, prevent addition of inflammatory cells or platelet, and offer protection to the scaffold. This fluoropassivation characteristic of the Zions fluoropolymer helps in thromboresistance. That is, fluoropolymer absorbs and retains albumin on the surface of the stent and repels the fibrinogen, which is thrombogenic. This leads to less addition of aggregation of the platelets of the stent surface. There's a minimum inflammatory response due to less leukocyte recruitment on the surface stent, and there's no inflammatory response as well when you look at the colors. And when you look at the functional healing, less platelet aggregation and minimum leukocyte recruitment finally leads to complete and functional endothelialization because of albumin and faster healing. And the safety and the efficacy data, eventually this is what will lead all of us to make a decision. When you look at the TALENT trial in 2 years, the safety and efficacy of sirolimus eluting coronary stent with ultra-thin strut, where they compared along with Zions lesions. The Supraflex biodegradable polymer sirolimus eluting stent, comparable to Zions everolimus eluting stent in all comer population at the end of 2 years, with no added advantage of biodegradable polymer over a durable polymer. When you look at the Supraflex versus Zions, the event rates were not greatly different. In fact, cardiovascular death at 1 year was less, but at 2 years almost similar. When you look at the device success rates, again, almost the same. So there's no advantage of biodegradable polymers. Next, the host reduces Polytech ACS trial. When you look at this, investigator-initiated open-label randomized multi-center trial comparing the safety and efficacy of durable polymer versus biodegradable polymer in ACS patients. When you look at them, the durable polymer Zions showed excellent outcomes compared to all other biodegradable polymer DES in ACS situation. You can see here, Synergy has the blue color. When you look at the cumulative events, it was significantly less in this durable polymer compared to the other, drug. What you can see here, the promers, although the event rates are quite significant, not too much, but there is evidence that duropolymer significantly helps. Safety in highest level of evidence, when you look at the randomized control trials network meta-analysis that were published both in BMJ. When you look at the everolimus selling durable polymer DS was found to be safer than the non-durable polymers. The results of the study reported here suggest no advantage of biodegradable polymer stents compared with newer generation durable polymer stents. When you look at what did the event rate say, the ARC definite stent thrombosis, when you look at Zions and biodegradable polymer DS, actually it was favorable to Zions to a certain extent. So stent in analysis include Synergy, Biometric, Flex, Noborian, or Cyro. Here, Synergy actually performed, Zymes with the durable performed much better than most others. When you look at when you talk so much about biodegradable versus durable polymer data comparisons, the cardio-based registry, real-world patients in Switzerland, Synergy and Zymes were compared head-on-head, more than 2,000 patients. Primary endpoint was composite death, target vessel myocardial infarction, clinically indicated target vessel at 12 months. In fact, acute events were slightly lesser with Zymes durable polymer, and primary endpoint, again, was better with durable polymer than biodegradable. In the ideal left main trial, again, patients with LMCA disease who were accepted by heart team for a PCI, when you compared everolimus eluting stent biodegradable versus permanent polymer, which is Zymes, at 12 months, clinical follow-up at 6 to 12 and 24 months, MACE at 2 years, when you look at it. The event rates, when you look at it, primary outcome MACE, 88.5% versus 85.3%. Synergy plus 4 months DAPT versus Zymes plus 12-month DAPT. Zymes stent showed significantly lower definite stent thrombosis than Synergy. When you look at it, 2.2 versus 0 with Zymes, but the MACE had slight difference between them. When you stent thrombosis occurred regardless of the DAPT period, when you use Zymes, whether you use DAPT for 0 to 4 months, 4 to 12 months, more than 12 months or 24 months, look at it, there is a 0%. With Synergy, I think within the first month, if there are 0 to 4 months, there is slightly increased events of 1.2%, and more than 12 months, 1%. So there is significant understanding that durable polymer also helps in spite of sharing the same drug between the two platforms. The clinical chronicles of Zymes and the preferred choice. See, I think most of us have our own platforms where we feel comfortable, and we know the clinical evidence are in favor of few of them more than slightly others, and they are more precise in positioning. So you can choose one of these with full understanding of all the characteristics. In the long-term follow-up, Reset had a 7 years, and Monzino had 10 years, and examination had 10 years data available to you. Long-term data cannot be beaten by anything else. When you look at the left main, there is Excel trial, ideal left main trial, and fluorescence UPL trial. Bifurcation, again, you have Excel bifurcation, Spirit 5 bifurcation. In diabetes, you have tuxedos, then sort out on bioflow. And again, I think I will quickly try and close the message to the my dear friends that definite stent thrombosis, again, when you look at it, it's unparalleled. Although it is less than 1.2, most of them fare well. So you could choose one of those which are comfortable, but some of us are happy with the platform that we have been using for large number of patients, which has been, everolimus eluting platform on a durable polymer. So message to carry is prefer an evidence-based treatment always. You may find certain challenges, but always stick with the most well-studied, which is given the longest, data and best outcomes, or a matchable, non-inferior outcomes. And give the best to your patient. Always look for long-term results that will give you a peaceful sleep. Thank you.
Thank you, Dr. Girish, for such a comprehensive and important presentation, particularly on this stent platforms. So any questions from Dr. Professor Smith Srivastava or Dr. Pardhi, Dr. Sahu or Dr. Jana? Please can ask your questions.
I have none, sir. Nothing, sir.
Dr. Jana?
I think you're muted, sir.
Yeah. No question, sir. I think it is very lucid and detailed presentation.
Thank you.
Okay. Um, uh, Dr. Girish, regarding the stent fracture, I mean, what are the properties you think are important to prevent that? I mean, that is one of the issues.
It's an excellent thing. There are three reasons when you can encounter stent fracture. One is if you put it in a very dynamic segment of the vessel, especially mid to distal LAD, or if there has been a bridging segment, is one. Second, if there is a significantly calcified segment where the lesion has not been prepped well, I think that is where the imaging is very, very crucial. The duty of the stent is only and deliver the drug. It is not the duty of the stent to expand the vessel and give you maximum luminal diameter. You should have prepped the lesion before implanting the stent. But unfortunately, most people with under preparation of the lesion implant a stent, and we are stuck with under expanded stent where you cannot take all your NC balloons, or whatever pressure you apply, you're unable to modify the plaque and get the best expansion of the stents, and there are acute angulations. These are a couple of situations where you encounter. And third is when you dilate the same stent with multiple diameter of the balloons, ectatic segments, or you have a proximal 3.5 and end of 38th stent, if it becomes 2.5 or 2.75. So again, these things lead to some amount of stent fracture.
Thank you, Dr. Girish. We'll move on to our last presentation by Dr. Chandan Saurabh Mahapatra, and he'll be talking about the challenging case of a PCI in a single coronary artery. So over to you, Dr. Mahapatra.
Yes. Good evening, everybody. And it's always happy to come back to our roots after excellent presentation by Dr. Girish and Dr. Sarath. Because my case is not so much complicated like you, Sarath, but it's a very interesting case of. Sir, am I audible, sir? Hello.
Yes, you are audible.
So my case is a intervention in a single coronary artery. It was an elective case, and what are the challenges we face? I'll be discussing in the subsequent slides. So the patient profile is the 58-year-old male diabetic hypertensive, presented elsewhere with effort angina for 1 month. They did ECG, which are showing some ST depressions in the infrolateral leads. Echo, there was no regional wall motion abnormality, and this LV function was normal. Troponin was normal. They did the treadmill. I think treadmill came positive, and angiogram was done, which revealed as a single coronary artery. Left system was resulting from the RCA, and mid RCA had 80% stenosis. L6 and OM1 contents had a 80% stenosis. So there it was a single center cath lab. So they advised a CT coronary angiogram and shifted to Bangalore for further plan of revascularization. So he underwent a CT coronary angiogram. Yes, he took a reference from 2 to 3 doctors, and finally he came to our center. So these are not the CT angiogram reports. Sorry, I don't have exact accurate 3D reconstruction images, but I'll read out the CT angiogram report. So CT angiogram report showed there was a common trunk of left main in RCA and is seen arising from the right coronary cusp. Proximal segment of left main courses between the outflow tract of right ventricle and the aortic root. Definitely, it's a kind of a malignant course. Distal left, after this, the distal left main extends away from the aortic root into the AV groove. There appears to be malignant course of proximal left main, but no intramural course. And it was reported that there is a 1 to 2 millimeter epicardial fat between the left main and RVOT and the aortic groove, which is the malignant course. So where the left main arises, the radiologist told us that there is some epicardial fat between the RVOT and the left main. So then we took the CT angiogram report and discussed with the surgeon. And while all this is happening, the patient doesn't want anything. He just wants a percutaneous and minimal invasive, that is percutaneous coronary intervention. So we thought maybe we can go ahead with this angioplasty without sending the person to surgery. And so this is the angiogram picture. You can see there is a the left trunk is arising from the RCA, and the mid RCA lesion was 80%. So we pre-dilated with a 3 balloon and stented the RCA with the 4x38 Zine stent with a very good result with after post dilatation, and we got a very good result. Now we turned our eyes into the LCX and OM1. So it was a tough thing. We passed a wire. The guide was not giving adequate support. It was backing off. We tried 2 wires, that also was not helping out, and the patient had some angina at the point of time. So we thought we'll take a Guidezilla. So we took the Guidezilla, advanced up to the LCX, and finally things changed, and it was easy. We pre-dilated with escalating to a 2.75 balloon, and finally stented 2.5 balloon, and finally stented with a 2.538 synergy stent, and post-dilated with 2.5 and 2.75 balloon, NC balloon at nominal pressures, adequately post-dilated, and this is the final result. Good result with no complications, and the TME3 flow was there. This is the final shot showing patent stent and with no complication both the vessels. So finally, in this case, Guidezilla definitely helped us out and bailed us out, we can say. I was a little nervous after taking 2 wires, also just not helping out. The guide was backing off. So by finally the Guidezilla helped out, and patient is following us. After third follow-up, he has not come yet. So hopefully he's fine. We discharged on the 3rd day with the adequate antiplatelets. So coming to the discussion, a single coronary artery is definitely a very rare congenital coronary anomaly. Incidence has been reported 0.02% to 0.098% in various angiographic series and studies. The course may be pre-pulmonic, retroaortic, interarterial, and septal. Ours was the proximal stump was interarterial. Definitely some malignant course is there. And this is a modified Lipton classification. Depending on the ostial location, if it is arising from right sinus of Valsalva, it is R. It is arising from left sinus of Valsalva, it is L. Anatomical distribution, type 1 is the solitary vessel coming either a normal right or left coronary, or type 2 is one coronary artery arising from the proximal part of the normal located coronary artery, R2 or L2, or 3 is the separate origin of LAD and LCX from the right coronary clasp. According to the course, A is entered to the great vessels, B is between the great vessels, P is posterior to the great vessels, S is septal, and C is combination of over. Ours was likely R2, and there's a other Ritagile function classification. Class 1 is benign, class 2 is fixed myocardial ischemia, class 3 is sudden cardiac death, and class 4 is associated with atherosclerotic cardiovascular disease. So this is a series of around more than 1 lakh patients of coronary anomalies, and it's showing most common is the separate origin of LAD and L6, and the the totally potentially dangerous and rare is the coronary anomalous coronary artery Al-Kappa and single coronary artery arising from the opposite sinus. Ours, that is R2, has been reported in some series 0.01%, so 17%. So relatively, it's a very rare anomaly. And definitely it's a fortunate. So the fortunately we have solved it without sending the person surgery. Of course, the patient was also not here. So take home message: intervention in single coronary artery is always challenging. Adequate. If you are doing an elective case, please prepare adequately and keep all the hardwares and guide wires, guide catheters necessary. Plan it and do it. CT coronary angiogram is essentially a tool for decision making and further course of action. And it's very much important for the angiographic information on the origin, course, and termination of such coronary anomalies. Always involve the heart team, the surgeons, and discuss with them. Keep confidence, have confidence, and take the thing forward. In my case, the Guidezilla helped me out, so I have a lot of confidence on it. Thank you.
Thank you, Dr. Chandan Saurabh, for your excellent case. So what you are trying to say that we should not do ad hoc angioplasty on this particular kind of anomalies. Is that what you're trying to say?
Yes, sir. We have to miss. We should not. We should plan it electively and plan it and do it. Better go femoral and plan it and do it. And don't be hasty. Always involve the surgeons regarding for a good result.
Dr. Padhi, any comments from you? Dr. Padhi? Okay, Dr. Sahu? Professor Srivastav?
Yes, there are two things. What other difficulties you had anticipated, and what were your plans for that?
Sir, actually, we thought the malignant course may sometime be difficult for the patient. We tried to convince him, but he was not ready. And we thought the epicardial fat, which was there, might protect us from the, might protect and might save us, might save the patient. It may protect the compression of the thing. That is that with that confidence and with the patient consent only, we took for the surgery. Second thing was when I was doing it, I thought we'll change the guide. When it was not giving adequate support, I was thinking to change the guide. But luckily, my senior was there. He told, let's try the Guidezilla. So we didn't need to change the guide thing, sir.
So consent actually here, between the two parties, we are the learned ones, and the patient is not the learned one.
Yeah, sir.
It's a big stake that you are taking. The third thing that are you worried that interarterial course, it may result like last time we were just moments ago we were discussing, it can land up with more fractures or stent crash.
But sir, stent was not in that part, sir, where the interarterial course was there, sir. The stent was down, sir. So I don't think that might be a problem, sir. But future wise, we don't know when if it's a strenuous thing or thing that I'm not sure, sir, about that. But fracture, stent fracture, very unlikely with this.
It was down.
Yeah. Yeah.
Dr. Girish, any comments? Okay, Dr. Jana.
Excellent case, sir. I think that all these cases are so rare that each case needs its own improvisation and approach. It's very difficult to say what applies to which case.
Yeah.
Ultimately, it's improvisation. Yeah.
You can't even predict what will work.
Yeah, that's what.
Because we are so
Professor Srivastav, just to share with you, or you share with us, at what point of time do you think that you don't have anything on the left cusp? I mean, when do you take a decision on that?
Sorry, I couldn't get that question.
That you do not have actually any artery on the left cusp at all.
Yeah.
What point of angiography you start thinking about?
Maybe after sinus shot, after 2 or 3 attempts of trying to hook the left system, if I don't get, I try to take a sinus shot, and then I take a sinus shot in all the 3 sinuses. So that way, maybe I can catch hold of any other artery arising from any other place.
I think it's extremely important, I think, to do these cases electively, because you need to do a CT angio really on these cases after that, because to find out the intramyocardial course, intraarterial course. And Dr. Chandan, I don't know how friendly you are with surgeons, but in our part of the world, we are not that friendly, because they don't like us doing left mains. So, yeah. But I think it's a very good case which you presented. Any other points we want to discuss? Any of the expert panelists, or we can bring an end to this session then?
Sir, I have a question, sir. Take the case key. If the Guidezilla is not available, or what else guide we can use for this, sir? Any guide, especially for the L6 to give, because the RCA definitely was not giving, JR was not giving the adequate support. If Guidezilla was available, but if the Guidezilla is not there, what else we can improvise, sir? I took 2 wires, that also was not helping. So any other guide in this case, sir? Any specific guide that might have helped? Just
Dr. Jana, what about the cuttings? Sorry, about the ALs?
AR1 maybe I will try, because of the shorter curve, it might fit in.
Professor
So if you
Srivastava,
have
how comfortable are you doing a case with not so good guide cap support?
Definitely not very comfortable.
Yeah.
But that sometimes happens even, today's experience, I was doing a CRT and it was a long sinus, a broad sinus, and a very narrow target
Entrance.
vein.
Yeah.
And I had to cannulate at least 5 times. And it had a very bad RA and RV entry. So every time, whenever I was taking the sheath out, that jerk was pulling everything out.
Everything out.
But finally, I planned that I'll hook that, I'll keep that sheath inside the coronary sinus itself and tear from there. It tears at such a speed that it does not before it could make a jerk at RA-RV junction.
Bring it out. Yeah.
I'll pull it out. That way it worked.
Yeah, I think with the introduction of
Right,
the auxiliaries and all, I think we're in a better position. Even without good support, we can still get away with the angioplasties. But I think first of all, for beginners, and I think also as a learning thing, you need a good support, coaxial support of any guide cap to do a good angioplasty. So that's very, very important.
One should not fear implants. That is what I feel.
Yeah, absolutely.
That fear keeps us away, but they have a very good support. If you are very careful in using them, they are very excellent support.
Yeah, thank you, Dr. Chandan, for your excellent case.
Yes, sir.
So I thank all the speakers and our expert panelists for making the first day of ODISHA Live a great success. So I hope you have a good evening with the IPL eliminator match going on. Good night, everybody, and we'll see you tomorrow. Actually, we have a second day, so I request all of you to, if you could, have time to join tomorrow again. Thank you.
Thank you, sir.
Thank you, sir.
Thank you. Bye-bye.
Bye.